Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues and PGs, today we shall discuss some important aspects of using beta blockers in patients with liver cirrhosis. Till now, we have discussed that using beta blockers in patients with portal hypertension is vital and very important to prevent the first decompensation. Today, we shall discuss what are the contraindications of using beta blockers in cirrhotic patients. Then we shall discuss when to reduce the dose of beta blockers or even stop the beta blockers. And lastly, we shall discuss the commonly reported side effects of beta blockers in cirrhotic patients. So, as I said that today's discussion is about the important aspects of beta blockers in portal hypertension. We learned in the first part of the discussion that this is the hepatic venous pressure gradient, which determines that what is the stage of the chronic liver disease. If it is less than 5, it means there is no cirrhosis and it's a normal portal pressure. But if it is more than 5, then the patient has got advanced chronic liver disease or cirrhosis. In the first stage of compensated liver cirrhosis, this portal pressure is from 6 to 10. And in the second stage of the compensated cirrhosis, it increases than 10, but it is less than 13. So 11 to 12, this is the second stage of compensated cirrhosis. And this is the pressure when the varices appear. And when it increases, it rises above the 12, then the varices rupture or the ascites develop. So when the portal hypertension is more than 12, it means either the ascites will appear or the varices will rupture. But from 11 to 12, this is the clinically significant portal hypertension, but it correlates with the stage 2 of the compensated cirrhosis. And this is the reason that the beta blockers has a vital and main role in the patients with portal hypertension to decrease the first event, that is the ascites or the varices to bleed. We also discussed this in the last part, that when a patient is in compensated cirrhosis, the patient remains asymptomatic and a patient has got the longer survival. But when a decompensation event happens, like the bleeding or ascites, then the patient's survival is severely compromised. And this is the reason for the patient becoming decompensation is the development of the clinically significant portal hypertension, which is more than 10. This is the clinically significant portal hypertension. And I also discussed with you in my previous parts of this discussion that when we presented our data of more than 2,700 patients in the APASL 2016, and this ascites was the most common presenting decompensatory event in these almost 3,000 patients. And this is true in each and every country and scenarios. We did discuss that the indications for beta blockers in cirrhosis are that they are indicated in the prevention of the decompensation. They are indicated in prevention of the first variceal bleeding. They are indicated in prevention of the variceal rebleeding, and they are indicated in prevention of the portal hypertensive gastropathy. So they has got a very wide and vital roles to be achieved in the portal hypertension patients, and not only the prevention of the first or the rebleed, but also prevention of the decompensation. And then we discussed in the last video that after diagnosis of cirrhosis, the next step is to determine whether the patient has clinically significant portal hypertension or not. And to determine whether the patient has got clinical significant portal hypertension, you don't need to check the hepatic venous pressure gradient in each and every patient. You can take the help of the EPRI and FAB and FibroScan. And this I discussed with you that depending upon the EPRI, the FIB4, and the FibroScan values, you can see if the EPRI is more than 3.5, if the FIB is more than 5.5, or if the transit elastography value is more than 25, it means the patient has got the clinically significant portal hypertension. So this first step is, then once you have made the patient has got cirrhosis, you need to decide whether the patient has got the clinical significant portal hypertension or not. And when the patient has got the clinical significant portal hypertension, then you start this patient on non-sedative beta blockers to prevent the decompensation. The role of the using beta blocker is not only the prevention of the venous bleed or development of the secondary bleed. This is to prevention of the decompensatory event and mainly the ascites, and I showed with you the discussion. So you have made a diagnosis, the patient has got cirrhosis, and you think the patient has got the clinically significant portal hypertension, and you want to start this patient on the beta blocker. But what are the contraindications when you want to start the patient on beta blocker, but you shouldn't? So the contraindications, they may be absolute or they may be relative. Relative contraindications are when a patient is diabetes and the patient is uncontrolled diabetes, that patient has got multiple spells of the hypoglycemia, or the patient has got the Raynaud syndrome. So these are the two conditions when you treat the underlying diabetes and prevent the hypoglycemic events, or treat the Raynaud syndrome. And when these underlying conditions, they are helped out, they are treated, then you can start this patient on the beta blocker with carefully. So these are the relatively contraindication. The absolute contraindications are when the patient has got second or third degree AV block and there is no pacemaker. So these patients, if these patients are on the pacemaker, then you can start this patient. You can weigh the benefits and risk in such patients. But if the patient has got no pacemaker and the patient has got second or third degree AV block, then the beta blockers are absolutely contraindicated. If there is critical limb ischemia, the patient has developed critical limb ischemia for whatever the underlying cause it may be, then again the beta blockers, they are absolutely contraindicated. Asthma is a very common condition. So asthmatic patients, again, they are the beta blockers should not be prescribed to these patients, and this is very, very important. So the cardiogenic shock, if the patient has got the cardiogenic shock, because these are the comorbid conditions, again the beta blockers are contraindicated. And if there is a coronary vasospasms, again the patient is should not be given the beta blockers. And if there is known hypersensitivity for beta blockers group of drugs, then again this is an absolute contraindication. So when you want to start the patient on beta blockers, you should exclude these absolute and relatively contraindication before starting a patient on beta blockers. When to reduce the dose or discontinue the beta blocker? If you have started a patient on the beta blockers, the propranolol or carvedilol, and the patient has developed the hypotension, systolic pressure has gone less than 90, or arterial pressure less than 65, so you need to either reduce the dose or even discontinue the non-selective beta blockers. If the patient has developed acute kidney injury or hepatorenal syndrome, again, this is a group of patients where you need to reduce the dose or temporarily stop the beta blockers. Or if the patient has developed hyponatremia, when the serum sodium is less than 130 milliequivalent, so again, this is a group of patients where you need to reduce the dose or preferably discontinue the non-selective beta blockers. What are the common side effects? You started a patient on beta blockers and the patient is very regular, honest with taking these drugs. What are the common side effects which the patients present and they can develop? One is weakness, generalized weakness, asthenia, aches and pains at times. Shortness of breath is another reported adverse events. dizziness, they feel dizzy, especially in the morning when they get up or when they sit for a long time, and then they get up, the dizziness, blackouts, the hypertension, the gastrointestinal symptoms. These patients may develop nausea. These patients may develop constipation. So this is another, and most of the times we don't think that these may be because of the beta blockers. We go for the other causes. So if the patient is on beta blockers, this is another one of the commonly reported side effects. And of course, the in male patients, the sexual and erectile dysfunction is the reported common side effects of these patients. And you need either to decrease the dose or counsel the patient or go for the alternative options. So, dear colleague, these are the few side effects of our patients that when we use the drugs beta blockers in the cirrhotic patients, and we know that the beta blockers is a very vital role and very extended role. So we need to exclude any side effects of these patients. We knew before starting the patient, we need to exclude any contraindications which may be absolute or relative, and we must be knowing that when to stop the drugs or the reduce the drugs during the course if the patient develops different sorts of the complications. This ends our discussion on the use of beta blockers on the in the portal hypertension patient, but we must realize that beta blockers has changed the perspective of cirrhotic patients. When we make a diagnosis of cirrhosis patients, this is our role that we should look for the complications present. We should make an idea what sorts of what level of portal hypertension is there, and then we should need to intervene in these cases. Thank you very much. See you in another video on the topics of pathology. Khuda Hafiz.